All right. Well, welcome everyone to our next edition of High Rounds. We are glad to have Dr. Erin Reid, who is here today. I'll just read her bio. Dr. Reid is a professor of medicine at UCSD Moores Cancer Center, focused on advancing the science and treatment of hematologic and HIV-associated malignancies. Her goals encompasses three main areas. Number one, improving prognosis, pathophysiology, toxicity mitigation, and elucidation of therapeutic mechanisms through clinical translational research and curation of clinical guidelines. Number two, improving health access and outcomes for marginalized populations through advocacy and research in social determinants of health. Number three, advancing hematology care broadly by mentoring and educating future physicians and physician scientists. She holds local and national leadership roles in these arenas, including the vice chair of the AIDS Malignancy Consortium, Hematologic Malignancies Working Group, protocol chair of lymphoma and Kaposi sarcoma clinical trials, co-chair of the National Cancer Center Network Guideline Panel on Cancer in Persons Living with HIV and Kaposi sarcoma, and member of B-cell lymphoma panel, director of the preclinical hematology course for UCSD School of Medicine and School of Pharmacy, and co-founding director and chair of the American Society of Hematology Medical Educators Institute. So as you can see, she is an expert in all of these fields, and we have had the pleasure of having her work with many of us at the Owen Clinic over 20 plus years, I would say now. And so we are glad to have her. She's going to be talking today about KSHV, immunity and cancer, harnessing insights into viral pathobiology for therapeutic intervention. So go ahead and take it away.
Thank you, Daniel. All right. Well, I miss being with you all in person, but I'm glad that we still get to collaborate regardless, and look forward to many, many more collaborations going forward. I am thankful to have funding through NCI and CTEP supporting my trials, including my KSHV related condition research. So today I'd like to just go over a little bit about the factors involved in KSHV tumorigenesis, and thinking about sort of lytic versus latent genes and syndromes that tend to be manifestations of a lytic versus latent state of KSHV. Become familiar with the spectrum of the KSHV associated conditions and understand the role of immune function impairment in these conditions, and explore some emerging disease control strategies for them. So, human herpes virus 8, KSHV, discovered in 1994. The virus was discovered after the condition called Kaposi sarcoma had been described for many years. So Yuan Chang and Patrick Moore identified this oncogenic gamma herpes virus responsible for KS. So it can be transmitted via asymptomatic oral shedding and other bodily fluids. Cancer, we think, is emerging only after years of dormancy in the context of immunosuppression. Severe T cell depletion or inactivation was what we were seeing sort of initially as our main triggers when this was discovered. We do see data suggesting that the HIV-related immunosuppression is higher risk than other forms on average. For example, about 300-fold in one study with advanced HIV versus other forms of immunosuppression. It does appear that HIV directly can interact and support the KS tumor cells via the TAP protein, which itself induces growth of KS spindle cells, and we see associated with increased expression of adhesion molecules and cytokines. VEGF and IL-6 go up in the context of TAT, so more of a direct virus-to-virus contribution to the issue. Seroprevalence varies by different areas of the world, as you guys, I'm sure, very aware. And this is just a sort of a heat map here that we can see places that are reporting. We know that it can affect several different types of cells, including B cells, which we think are likely the predominant latent reservoir for KSHV infection within humans. Endothelial and epithelial cells, which are probably manifestations of KS at least. And then we also can see infections in dendritic cells and monocytes, fibroblasts. Now, we think the majority of primary KSHV infections are asymptomatic or minimally symptomatic. And one point that I'd like to make right now is that when we're seeing the tumor cells for KS and also another condition, lymphoma, that we'll talk about associated with KSHV, the KSHV viral expression patterns we are seeing in that context is predominantly a latent viral expression pattern. So just an overview of the life cycle. You can see after budding to integrants and endocytosis, the viral DNA can be shuttled toward a viral latency state using KSHV LANA protein, which creates a viral episome within the host chromosome, versus a lytic replication pathway, which will lead to the budding and or actual cell lysis of the infected host cell. There are multiple genes modulating host signaling, and then many of these that we think are contributing to tumorigenesis. So I'll point out here, there's a viral G protein coupled receptor up here on the membrane that is involving multiple pathways, including eventually the mTOR pathway. We have V-flip that's affecting NF-kappa B, and viral IL-6 that is elaborated by the cells that are infected in an lytic state. So here are some of the proteins that we think are contributing to transformation and or persistence and survival of tumor cells that KSHV is associated with. So the V-flip protein causes constitutive NF-kappa B activity, which is blocking apoptosis as an endpoint. We know that LANA is inhibiting tumor suppressors, so it tethers, again, the episome to the host chromosome for replication during cell division, and we see impaired or lower levels of tumor suppressors such as P53, von Hippel-Lindau, which, again, impair apoptosis and lead to an environment where cells are resistant to cell death, promote cell survival, tolerance of hypoxic conditions, and whatnot. Now, how this is being done by LANA is that it is actually targeting these proteins, as well as others, for proteasomal degradation via LANA's ubiquitin E3 ligase activity. Another protein, so those were latent proteins, but this lytic protein, the KSHV lytic protein, viral G protein coupled receptor, it's a homolog of the CXC alpha chemokine receptor that we also see induced by HIV TAT. It, we think, is involved in transformation. When we tried to find different genes within KSHV, or not we, but others tried to find genes that were involved in transformation of by KSHV, this was the one gene that on its own we could see transformation effects. So it eventually unblocks a block on the mTOR pathway, essentially leading to activation of mTOR pathway. And in the MAP kinase and P38 pathways, we see the increased HIF1 alpha again, VEGF. Ultimately, FRNB2 via multiple pathways is induced, and this helps establish in endothelial cells an arterial phenotype characteristic of Kaposi sarcoma. We know that signaling through FRNB2 is basically required for KS viability, which has made it a target for signal blockade, and we'll talk about how we have monopolized on that in a bit. All right, what about KSHV microRNAs? So here are three that seem to have oncogenic potential. So we have MREK12-3, which is involved in promoting endothelial cell migration and invasion via that AKT-mTOR pathway. We have K12-10A, which is involved with transformation, and then K12-11, which looks a lot like our microRNA 155. And we know that when you downregulate that, you have terminal differentiation of cells, loss of proliferative potential, but in this case, we would essentially be upregulating a homolog, and we see hyperproliferation and lymphomagenesis in models of this. So what are the KSHV associated conditions? And here's what I'd like to go over with you today. Obviously, Kaposi sarcoma. It is a spindle cell. Pathologically, we think it's an endothelial cell origin. And then multicentric Castleman's disease that's associated with KSHV, which is specifically a plasmablast. And then primary fusion lymphoma, which is where KSHV is transformed B lymphocytes. There are other KSHV-associated lymphomas that have been delineated by the World Health Organization, specifically a large cell lymphoma developing the context of the KSHV-associated Castleman's disease. And then finally, KSHV inflammatory cytokine syndrome, and I've grouped it with multicentric Castleman's disease because those two are where we see a lytic state, a lytic manifestation of KSHV driving the clinical scenario. So let's start with KS. So this is not a heat map of the virus, but of the KS incidence on the top in blue and mortality in the bottom in the orange reds. And we see here, obviously, sub-Saharan Africa, one of the sites that are one of the areas of the world that is most significantly affected. It's basically accounting for 73% of the global incidence and over 85% of case-related deaths as of 2020. Looking in more closely, this particular study, this Globocan report, looks at what is the leading cause of cancer mortality across the world. And if you look at the pink areas, we see that KS was the leading cause of both cancer incidence and mortality among men in Mozambique, Zambia, and Uganda in 2020. So I know you all are very familiar with KS. The clinical presentations are predominantly cutaneous, sometimes oral, but all these other areas, and essentially every area of the body could be affected. I think one area that we don't think about as much is we can see lytic lesions in KS, as you might see in multiple myeloma. Now, not usually progressive, and I've yet to have a patient who's had a skeletal complication from a lytic lesion in KS, but it's been more of an incidental finding. So some interesting side note to be aware of. But obviously our concern about the risk of mortality from KS goes up with more advanced involvement, where we're seeing pulmonary involvement or GI involvement that can lead to fatal complications. Very commonly in advanced KS, we'll see lymphedema, which we think is both due to potentially lymphadenopathy caused by KS, as well as direct involvement of the lymphatic channels, as those are also lined by endothelial cells and are subject to transformation. So its manifestations can vary within a person and between people. And the color of the lesions is going to be quite variable, again, depending on the baseline skin tone of the person involved, as well as sort of the age of the lesions, and what kind of form they take on. Just examples of some of that variation here, and a biopsy demonstrating this sort of extravasation that's very common in the dermis of a skin lesion. So thinking about what helps to drive KS and KSHV, people who have KSHV within their system, and it's a gamma herpes virus. Once you have it, you get to keep it, as with all the herpes viruses. So this is a lifelong condition, right? Basically, immune function seems to be one of the most important factors, and we know HIV-associated immunosuppression contributes to KS. Iatrogenic immunosuppression is also a significant issue, and specifically glucocorticoids I will call out and we'll talk a little bit more about, but also things like rituximab, which rituximab is a B cell monoclonal antibody targeting CD20. It's not even directly attacking our T cells as we see in HIV, but can definitely be associated with significant flares of KS. So just to note that not just T cell immunosuppression is important. I think one of the major things that we're seeing in our very well controlled population who have HIV is, even though their viral load has been undetectable for years, and maybe their CD4 count was never even known to dip into the low range, let alone below 200 or below 100, we are seeing KS in this population. And we're seeing KS in our patients who have KSHV who don't have HIV as well. And a lot of that is probably driven by immunosenescence, as well as iatrogenic exposures. And so that's just to be aware of these other risk factors being significant beyond HIV infection is important. Host HLA seems to be modulating on host side people at risk of more significant KS, where HLA-DR5 is associated with progression, where DB1 inversely associated, maybe somewhat protective. KSHV viremia, when we see higher levels of KSHV viremia, I would say that's not as consistent with just plain old KS, but would make you think of a lytic viral syndrome like Castleman's disease associated with KSHV, or KSHV inflammatory cytokine syndrome. And then the viral IL-6, we think one of the many things that the virus makes implicated in development, and it can be, when you see it increase, can be associated with a pro-inflammatory phenotype of KS, and is definitely involved in KICS and multicenter Castleman's disease. So thinking about how KS is going to present, this is one of the most important things I like to discuss with my patients and colleagues that are managing KS, is that the spectrum of disease is highly dependent on the degree of immunodeficiency. This seems to be one of our strongest factors that will predict how significant a person's KS course is going to be. So when you have more mild degrees of immunosuppression, I don't even like to call KS lesions cancer at that point. I think they are more, the situation is more akin to something like HPV-associated verruca. You don't like it, you don't like the way it looks, you don't like the way it feels, but it is not life-threatening and not likely to become so in the case of mild immunosuppression unless the degree of immunosuppression changes. So we're usually seeing limited cutaneous KS in that context, sometimes even an oral lesion, and occasionally something we'll find inside endoscopically or whatnot, often incidentally. So that's the one end of the spectrum. And then on the other side, when we have more advanced immunosuppression, that's where we're more likely to see KS behaving like a cancer. And that's when it's more appropriate to manage it like a cancer, because it can become life-threatening. And I'll point out that no matter where you are on this spectrum, optimization of immune function and reversal of immunosuppression is key. If we don't do that, then we are going to have limited durability and depth of benefit from KS directed therapies. So thinking about immunosuppression some more, and glucocorticoids, I want you to think of being above and beyond just their immunosuppressive effects, and taking you back a wee bit to the dreaded coagulation cascade and regulatory factors from medical school. Since I'm a hematologist and I love all these things, we know that the coagulation cascade and things that regulate our coagulation and hemostasis are actually closely tied to inflammation and infection response by the host. So it turned out that many years ago, in '97, our team, including Prakash Gill, who's one of my colleagues I collaborate with at USC, glucocorticoids induce directly KS cell proliferation, and beyond just being immunosuppressive, they can do this through regulation of TGF beta. And so this has to do with plasmin and TGF beta going from its latent form to its active form, and how KS is then affected by the TGF beta in that context. So it is dose dependent. We do know that the more significant doses of glucocorticoids, the higher the risk of a KS flare. But I just want the world to know, this is my Pepsi commercial, that I want the world to know that even local glucocorticoids can be responsible for KS flares. And I'm talking topical, inhaled, intranasal, interarticular. So those things are not safe, they have risk. And obviously, the more you use, the higher the risk on average. But it is bad enough that every KS patient that walks into my practice, I try to add glucocorticoids to their allergy list, explaining it's not a true allergy. And if they were to have a severe allergic reaction that was causing respiratory distress, the steroids are still something that they could use in that context. But I want them to avoid steroids except for extreme need. So I talk about using topical Benadryl and all these other things, depending on what the situation is, where you might want to use a steroid to try to avoid it when possible. And obviously, there are situations where it's not. But if I could have people remember and spread the word on one thing, I think this would be it, regarding KS and KSHV. So our goals of therapy for KS are basically rooted in the fact that this is a virus you get to keep for the rest of your life. And so the potential for it to transform cells is ongoing for the rest of your life. In that context, it is not curable. Can you get, I guess, a control of a specific outbreak of KS? You could, and you could get a complete remission, but that does not modulate the future risk. Treating KS today doesn't modulate the future down the line risk of more KS within a given person. Whereas in other cancers, for example, lymphoma, if it's an aggressive lymphoma, we can treat with curative intent, reducing the long-term risk of relapse if we're giving optimal therapy. So this is a very different situation from other cancers, and another reason that this kind of makes it distinct from many cancers that we treat and cancer management strategies. So we talked about how the persistent risk factors of the virus and immune dysregulation are the main things that would contribute to this, and talked about optimizing immune function in this context. So obviously for persons with HIV, antiretroviral therapy, staying on it and avoiding holidays, really important. So the manifestations, how severe the KS is going to determine our goals of therapy and how we manage it. For the more limited disease, we're going to consider it more like warts than cancer, and we're going to prefer local measures over systemic therapy. Visceral or advanced cutaneous disease, again, more common with advanced immunosuppression, and the more significant it is, and the longer it's been there, the less likely we are to get like a technical complete remission by the definitions that have been used over time in clinical trials. So our goals are remission of visceral disease, improvement in cutaneous disease, reduction of swelling. Essentially, I'm going to treat with a given agent as long as it's tolerated until I get a maximal response. And if I'm starting to see a plateau in response, then I'm going to switch to another agent for therapy. Or if the response is good enough and the patient is satisfied, then we would take a break and keep an eye on it. Lymphedema as a common complication of KS, I just want people to note it might not be completely reversible, even if we can get rid of all active KS disease that we can find, like on the skin or whatnot, because there can be lymphatic scarring. So I think when you have someone who is at risk of KS or has history of KS, and you're seeing edema, you want to think about that early because we don't want to wait very long to start KS-directed therapy in that context, to minimize the chance of having a long-term lymphedema complication. And so working with our colleagues in occupational therapy is really, really helpful. So here are some examples of the different treatments that we would use on the limited KS side. For local therapy, topically, the thing that I think has the best activity currently is imiquimod. Cryotherapy is very helpful, especially for small lesions. Surgical excision, again, for small lesions. And this is not something you're going to be doing Mohs surgery for, I want to point out, because again, the virus that can cause these lesions is still in the body. And so you doing wide margins of it for resection is not going to prevent long-term issues like it might for melanoma. You can do interlesional chemo. I haven't had a case where we've done that in a long time, but it is an option. Radiation as a local therapy is another tool, and I think very useful for certain situations, particularly ones where these others are not likely to be as helpful or just not as practical. Like sometimes surgical excision is not practical for certain lesions. So radiation can be a good tool. I just want to caution that a lot of radiation or radiation in certain areas can increase the risk of long-term complications like wound healing and lymphedema and secondary skin cancers. So if you send someone radiation, they're going to get radiation. So we should make sure it's really the right thing to do before you send them. Visceral advanced cutaneous disease, reversal immunosuppression, again, really important. So antiretroviral therapy if somebody has HIV, and systemic therapy is going to be added to it. So our sort of standard chemotherapy, liposomal doxorubicin, paclitaxel. I prefer the doxorubicin because it's a bit less neurotoxic, and less likely to have some infusion reactions, although I've seen some of those recently with doxorubicin as well. But they both have similar efficacy. And so when I really know I need to treat somebody and treat it fast and get a really good response, particularly if they've got visceral involvement, these are my go-tos. We do have newer strategies that we are getting more and more information about over time, and we'll go over some of these. But like immunomodulatory drugs, like thalidomide, pomalidomide, lenalidomide, bortezomib, which is proteasome inhibitor. mTOR inhibition is particularly important for transplant or immunosuppression-associated KS where you need ongoing immunosuppression. And then immune checkpoint inhibitors have recently shown some activity. So we want to continue again until you have a plateau in response, and then stop if this response is acceptable and switch if it's not. One other point I'd like to make is that if you've got relapse of KS, if you had tolerance to a prior therapy, and especially if it had a decent duration of remission, and or you stopped it early before you were really, getting its maximal benefit, going back to that initial therapy is totally fine and can work in many cases. All right, this is another point that I want the world to know. Not quite as important as the glucocorticoids, but it is really important. And here's an example on the left of a person who was on one of our trials years and years ago. And this is not severe KS, the lesions that we're looking at on the left at baseline. But you can see after therapy that there is still pigmentation, right? And when I measure those lesions, they don't seem to have improved significantly by the size. The size is very similar, but they flattened to the extent that they were raised, which was minimal. And we see that the pigmentation has faded. And when I feel these lesions, I spend a lot of time touching the lesions to see if I'm feeling dermal thickening. And if I'm not feeling thickening of the skin in that area, then it's very likely that what we're dealing with is tattoo effect. And so what is the tattoo effect? Well, again, going back to the biopsy, what we see in the dermis a lot of extravasated red blood cells because this is a tumor of endothelial cells. The endothelial cells are supposed to make blood vessels when they're working, when they're normal and not tumors. And they basically are making tumor blood vessels once they're transformed. And they're just not as good and they're very leaky. And that's how we end up with all this extravasation of blood. So all the iron that's in our red blood cells that's important for gas exchange, all that iron is ending up in the tissue, which is essentially causing pigmentation of the tissue, even if you get rid of all those spindle cells that led to the iron getting there in the first place. And so that is essentially a tattoo, and depending on how much iron got in there, you may not completely ever get rid of the pigmentation in that area. It probably will fade with time. And particularly if it was a minimal amount, then it may fade to back to normal color. But oftentimes you will see some residual pigmentation. So that's what I call the tattoo effect, and we're not treating that with chemotherapy. All right, so getting back to the virus and some of its proteins involved in driving cancer. So we talked a bit about the LANA protein, and LANA is the one that we use to diagnose on biopsy KSHV involvement in a tumor. We have immunohistochemistry for that. But LANA, as we mentioned, is involved in inhibiting tumor suppressors like p53 and von Hippel-Lindau, leading to tumorigenesis and persistence of tumor in that state. The mechanism of inhibition, as I mentioned, was via its ubiquitin E3 ligase activity. And so that's targeting these proteins for proteasome degradation. So that raises the role for proteasome inhibition in the control of KSHV-related cancers. So bortezomib was in the late 90s initially studied in a setting of myeloma, and it was the first in class therapy proved. It was approved for multiple myeloma in 2003. When someone looked to see what could induce EBV lytic activation, a related gamma herpes virus, out of 2,500 compounds that were FDA approved at that time, it was the most potent inducer of EBV lytic activation of all of them, by far. We've since learned that it induces an unfolded protein response, and there's a bunch of other detail we get into around that. But we see lytic activation of viruses, which can lead to direct cytotoxicity. So the virus that caused the tumor potentially could then be killed by, the virus could then potentially kill the tumor that it caused if it went fully lytic and lysed the cell, versus going lytic to the point of budding and whatnot and having viral proteins expressed, which could lead to more immune response to the tumor cells. There are also indications that it may have anti-HIV properties, and I don't have time to get into that today, but we can certainly talk about that offline. So years ago, we completed enrollment to this trial for bortezomib in KS, and this was our AIDS Malignancy Consortium 063 trial. And this was a dose finding study. So we started with a very low dose and ramped up in a small cohort. We had 15 evaluable subjects, our participants at the end, and our median time to response was pretty quick. It was 2.1 months. And we had about a 60% response rate overall over all the doses, even including the low doses. You can see the lowest dose, we had 1 out of 3 that had a response. But the highest dose, 5 out of 6 had a response. So we did not have dose-limiting toxicities. And one thing you might worry about is if we are inducing lytic activation, could we end up with one of those lytic syndromes? And we were worried about that. So we had built in aggressive stopping rules in that context, but this wasn't ever identified as an issue during this small study. So this was promising to show that there was some activity for proteasome inhibition, and it looked similar, at least in this small study, to the types of activity that we're seeing with Doxil and paclitaxel. So we actually have been moving forward on newer proteasome inhibitors to try to look at these for KS. We now, that bortezomib was IV, and then we developed it, we found that we could administer it subcutaneously, but still requires visits to an infusion center to get administration. We now have an oral proteasome inhibitor called ixazomib that, again, approved for multiple myeloma. So we're borrowing from the myeloma space. And we have been performing a trial for this in the AIDS Malignancy Consortium and currently enrolled 14 patients with KS, both HIV with and without HIV. We have a total accrual goal if the first stage goes well of 41. So again, we're looking at lytic activation, and we're going to be exploring some antigens that could be impacted by the KS, including things like p53 and von Hippel-Lindau. We also recently, I've been in contact with a company who developed a topical proteasome inhibitor and studied it in the setting of rosacea, where it was active and well tolerated. So we have a lot of people right now who have very limited KS, not really warranting systemic therapy, but not also loving our directed local therapy options. So we are wondering if this will be something that would have more impact than, say, topical imiquimod, which induces a local immune response. So I'm trying to get this study going over the next couple of years. There's a lot of stuff regarding triaging of protocols and whatnot in the AMC, and how long it'll take us to get it open, but that's something coming down the pipe. So another trial that we recently completed enrollment to and are looking to eventually expand is a different angle, looking at the angiogenesis signaling pathways. And we talked about Ephrin B2 being really important to establishing arterial phenotype of KS, and signaling through Ephrin B2 is important for maintaining KS tumor cells. So it turns out that Ephrin B2 and FB4, so FMB2 on the arterial side and FB4 on the venous side, those guys need to talk to each other. And during embryogenesis, remember how you have even the webs between fingers and whatnot, and those regress when we don't have the vascular supply develop. So you will have all these blood vessels developing, and if the venous capillaries and the arterial capillaries don't eventually meet, you will get regression, and then that's what we see during embryogenesis. Well, once these things are established, it's not as critical for maintenance of the KS tumors, or of regular vasculature, but this signaling is critical to maintenance of KS tumors. So we know that knocking down FMB2 will lead to KS cell death. So my colleague, Dr. Gill at USC, has been studying KSHV his entire career, and he developed this drug for KS. It also potentially has applications and seems to have activity in other settings, but essentially it's a soluble form of the FB4 that we were getting the signaling from the venous side with FB2, and basically blocking that signaling and blocking that bidirectional signaling and keeping that signal from supporting the KS tumor cell. It has some albumin that was fused to it just to give it a longer half-life. So we did a trial, phase 2 trial for KS, both HIV with and without, and we had partial responses occurring, which PRs are usually the best we get for the most part in trials, unless somebody had very limited disease. But we had PRs occurring in 70% of our participants, and the rest had stable disease. The median time to response was 4 cycles, with some as early as 1. We saw improvements in quality of life in those who responded, those whose tumors responded. And we didn't see the typical adverse events of cytopenias and neuropathy like we would often see with a lot of our chemotherapy agents. But hypertension was nearly universal, which is kind of a class issue for our angiogenesis range of blocking therapies. So not surprising, but something we had to definitely manage. Here are examples at the top of a person's lesions who was participating in the trial, and then some baseline pictures baseline at the top, and then post-cycle 7 on this study. And you can see even this very big ulcerating lesion that was on the shin is now just this really, very small nodule there. So significant improvement there. Here's another person who doesn't have a lot of pigmentation of their KS, but it's a lot of nodularity that you can appreciate with significant responses. And again, even after the second cycle, it had dramatic response. Okay, so we're going forward. We're trying to get FDA approval for that strategy, and we have, once we get all the data and the manuscript up, we will be seeking FDA guidance on what are the next steps to expand the protocol or a new protocol to seek that.
So Erin, just a
Yep.
time check. It's 8:42.
Yeah.
So, and we've got like 4 or 5 questions.
Okay. I'll
Just letting
this.
you know.
Thank you. Thank you. Thank you. So just quickly for KS Iris, which I know many of you have seen before, it's usually in the context of recent ART initiation, um, with rapid progression of lesions in persons who already had them, or even emergent KS that's just coming very quickly in its presentation and growing quickly. We see it more in the setting of advanced HIV. Basically, one of the things I want to point out here is, again, we don't love steroids for KS. So we don't want to use those if we don't have to. We would try to just keep going with antiretroviral therapy. We would start or continue systemic therapy, and I would usually be using liposomal doxorubicin because it's the one I have the best chance of working quickly. And then instead of glucocorticoids, we know that thalidomide has activity for iris in other settings, and have used that successfully for KS. And I've actually used lenalidomide or pomalidomide recently too, because we've demonstrated activity for KS, and they have a different side effect profile. So those are things to consider for KS iris, is addition of an IMiD instead of steroids. So just really quickly on the IMiDs, these have anti-proliferative effects, anti-angiogenic effects, and immunomodulatory effects, which is where we think the iris assistance comes in. And these are the three that we have that are currently available. Thalidomide did show activity. It does have a lot of neurotoxicity. So a lot of people were not able to continue on the trial. It was initially done years and years ago. The second generation lenalidomide is more potent. Main side effects typically are myelosuppression and skin rash, but more mild myelosuppression than we would see with something like Doxil or paclitaxel in somebody with advanced HIV. So that had activity, about over 60% response rate. And then our third generation had similar activity, as demonstrated by the NCI group. We have a study that we just closed enrollment to with pomalidomide, and we're waiting to see the results. I will say anecdotally, compared to something like Doxil or Taxol, if I had more significant advanced disease, I would be leaning more toward Doxil or paclitaxel than the IMiDs for control. I think this is better for more limited advanced cutaneous disease, if that makes sense. But we also have a parallel trial going on in Sub-Saharan Africa, and hopefully together the two of those will potentially go for FDA registration if we support what was seen with pomalidomide at the Siegel Institution NCI study. I'm just going to skip this for now and just clinical pearls overall for KS: avoid the glucocorticoids, optimize immune function. And that includes thinking about things like what are the other aspects of the person's life or other comorbid conditions that might be contributing to an immunosuppressed state. And I do not know if it's relevant and it's something I want to study, but I've seen a lot of people with sleep apnea recently in my KS clinic, and we know that sleep apnea can contribute to a hypercortisol state. And then lymphedema control is important. So we've already gone through sort of these different mechanisms. I didn't get into it, but rapamycin or sirolimus is a very good tool in the setting of transplant-associated KS, unblocking tumor suppressors, blocking angiogenesis, and thinking about using the virus to kill the cells that it created. Briefly wanted to just wrap up with these other manifestations of KSHV, which are the KICS, Castleman's disease, and primary effusion lymphoma. So the primary effusion lymphoma, KS has to be involved for it to technically meet the WHO criteria for what we call primary effusion lymphoma associated with HIV. EBV is often involved, and we think these two guys together are coordinating with their various different lytic genes to establish the pill, and then they have a latent state once they've established it predominantly. So more things to target. We did have activity when we used bortezomib, like we used for KS, when we used it for HIV-associated lymphomas. We saw activity in lymphoma as well, specifically with PEL, and we did see evidence of some lytic activation occurring without a lytic viral syndrome. KSHV has epigenetics involved in PEL that we think are important and could potentially represent treatment strategies. This is just an interesting study showing that initial KSHV infection affecting methylation of our host genes, and then over time with chronic infection, essentially causing hypomethylation as opposed to hypermethylation, adjusting our gene expressions leading to tumor profiles. So we think this has applications as a biomarker and potentially as therapeutic for epigenetic modulation strategies. So in the interest of time, I will skip this, but know that we can use the methylation status of CpG to detect tumor-derived DNA from our gamma herpes viruses, both EBV and KSHV, and again, using this as a biomarker. And we have some ongoing investigations with some other targeted therapies. We know it typically expresses CD30 in PEL, so we have a drug that targets that I have a case report showing some activity, looking at a prospective trial for that. IMiDs are being explored in combination with systemic EPOC. And then I'm doing a study with Dr. Waxman on the genomic and clinical prognostics of PEL that we're in the analysis phase now. And then finally, so we can get to our questions, I just want to quickly talk about the Castleman's disease and KICS. And know that Castleman's disease is a spectrum, and we have unicentric and multicentric. And within the multicentric, you've got the KSHV associated kind and the idiopathic kind. And we're just going to focus on the multicentric KSHV associated. And this is where you're going to see an inflammatory syndrome when it's active, where you will have patients with fevers, tender lymphadenopathy, splenomegaly, edema, high markers of inflammation, both C-reactive protein, IL-6, cytopenias. And it can be life-threatening. You can have essentially a cytokine storm, life-threatening condition. People can die from this. So what do we do about it? If it's current setting of HIV, you want to be on antiretroviral therapy, but it's not sufficient by itself. If it's transplant associated, you want to maximize the mTOR inhibition, like we would for KS component of the immunosuppression, minimize the other components, and then start chemoimmunotherapy. And I'm going to just tell you, rituximab plus liposomal doxorubicin is what we're using now. Rituximab was causing risk of KS flares, so that's where liposomal doxorubicin comes in. Liposomal doxorubicin is toxic against the lymphocytes that are driving this, is also going to keep the KS at bay or improve it, right? So I like to continue the doxorubicin after stopping rituximab once I get control of the clinical flare, just so we keep the KS under control because the rituximab lasts longer. Other strategies may be active, but I'll note that while the rituximab is better for HHV-8-associated Castleman's than it is for idiopathic, the IL-6 therapies are better for people who have the idiopathic kind, because in the setting of KSHV, it's the viral IL-6, or viral IL-6 often is predominant, and the anti-IL-6 drugs that we have right now are not as good at targeting that. Also, using rituximab reduces the risk of one of those MCD-associated lymphomas, so another reason that it's helpful. I'm skipping this. Finally, just talking about KICS really quick. So KICS was basically like we saw patients presenting with a Castleman's-like picture. Everything that you could think of with Castleman's disease, with the inflammation and the laboratory markers and the lymphadenopathy and splenomegaly. These guys did not on biopsy demonstrate the pathologic changes that we see with KSHV. And so they coined this syndrome, or with Castleman's disease, I should say. They did not have pathologic changes consistent with Castleman's disease. So we saw KSHV viremia, we saw all these other features, but no pathology that showed the same Castleman's disease like changes in the lymph nodes. And they coined this KICS, KSHV associated inflammatory cytokine syndrome. And just like Castleman's, it can be life-threatening. So we're going to manage it the same way we manage Castleman's disease. So when we have these people presenting with these inflammatory syndrome, in the setting of the KSHV being very high, I'm going to treat it the same way, whether we figure out if it's Castleman's or KICS. But I do want to know kind of more academically, especially kind of think about second line therapies and whatnot, if it is Castleman's disease. So we need that biopsy of the lymph node, excisional, as I always like for the lymphomas as well, right? So what we just in conclusion talked about is KSHV has multiple tricks that promote tumorigenesis and inflammatory syndromes. We have the lytic manifestations of Castleman's disease and KICS, and that these lytic proteins contributed to the initial oncogenesis of KS and PEL, but within established KS and PEL, we think it's predominantly in its latent state. We know immunosuppression really increases the risk of mortality from KS, KSIRS, and PEL. And optimizing immune function is a critical component of therapy in addition to the tumor-directed therapy. And our ongoing needs, we would love a vaccine for KSHV, as with HPV, to help prevent these problems in the first place. We need ongoing support for translational clinical studies that are targeting these viral pathways and immune responses and angiogenesis. And we desperately need expansion of our access to trials and therapy to the global sites of the highest disease burdens that are not here, even though we do need these things here for our patients here, but globally, and even obviously bigger problem. And with that, thank you. I'll wrap up.
Great. Thank you, Erin. I think it's quite clear why you're a worldwide expert on this. Thank you for that excellent talk. I see there's quite a few questions, and so I'll go ahead and start. There's a question initially when you're talking about TAT inhibitors or TAT especially. Has there been any in vitro work using TAT inhibitors?
In the setting of chaos, that's a
Mhm.
great question, David. If there is, I'm not aware of it, and maybe somebody else here might be, but I'm not aware of that.
And I think David also asked then, you were talking about lymphedema management. So two questions. How
Yeah.
early would you begin lymphedema management?
Yes, and immediately. And I have a sneaking suspicion. I know lymphedema management improves the risk of like secondary complications like cellulitis and whatnot, right? And when you improve edema management in general, you're going to improve the health of the tissue and probably the immune function of the tissue. There are some data that support this. So I suspect that improving lymphedema management actually can help prevent additional KS, maybe from coming into the place that is experiencing the lymphedema, that part of the body. So I try to encourage my patients to be aggressive about it, even if the lymphedema isn't limiting their activity. Um, and yes, it can definitely. I see another question about lymphedema from from Net. So, does it ever occur as a first presentation without visible signs of chaos? Yeah, it could. It definitely could. And sometimes we'll get to the cutaneous manifestation or some other manifestation, and that's just harder to diagnose, right? But lymphedema tends to be more woody when it occurs, especially the longer it's been there. So we'd like to catch it earlier, but it's something to think about for sure. Um,
And I
yeah,
think you see the question from Alan about
yeah.
you say no steroids, no
Steroids.
corticosteroids, but what if they have severe PJP?
Yeah.
What's your thoughts on
Yeah.
that?
So severe, anything that you would use steroids for, and you just feel like, this is really important to save this person's life. Yeah, I'll let you. I'll let you do it then. I won't get mad.
So
But
then I presume then you would use it and then just obviously closely monitor, and then
yeah.
if it comes up, then you get a call and then we treat it.
Yeah. And certainly if you already know the person has KSHV because they've had a KSHV related issue in the past, or or whatever, you just happen to know, then I think we are going to be like hawking for any signs of KS and low threshold to start systemic therapy, even if it's limited cutaneous KS or something like that, because I'm going to be like worried about a blossoming. Yeah.
And then at least the last question here for now, can you talk about any preferred or recommended workup beyond a thorough physical exam? I went to check additional labs, imagings for patients presenting for what appears to be limited cutaneous KS.
Yes, Adam, a great plant there because I didn't really go into that. Um, yeah, so my sort of rule of thumb is if it's limited cutaneous and they have like, I mean, really truly limited, like very minimal disease, and they don't have any pulmonary symptoms or GI symptoms, I'd ask them to do a stool occult blood test, but I'm not going to make them get scoped in an image necessarily. Now, for advanced cutaneous disease, I am going to ask for at least a chest x-ray and a fecal occult blood. Anybody with symptoms gets imaged, gets scoped. So if you've got pulmonary symptoms, you're getting scoped and a CT scan. Beyond the chest x-ray, we're just go ahead and get CT scan. And then GI symptoms, and that can be like nausea, it can be diarrhea, it can be bloody stools, whatever, pain, then we're going to get scopes. Yeah, great question.
Uh, I I did have a question, basic, but remind us why there's a male predominance typically and why we see it
Ah,
in more men than women.
so in okay, maybe I don't know. I'm not sure we know for sure all over the world, like in different parts of the world. Definitely, even in sub-Saharan Africa, we're seeing a higher incidence of males than females, but it's we see a lot more in women in places where the virus is more prevalent in the general population, right? Um, so we see in the US the virus is more prevalent in MSM population. So that's one reason that it may be, but I think there's probably other factors beyond that that we don't have a good reason for.
And then lastly, plug any research you're doing currently in KS that we can refer people to if you have any.
Yes, always. Almost always have a trial for KS. Like the current trial that we have is the oral proteasome inhibitor trial with ixazomib, and so that's I'm the protocol chair for that one, and we're that one's going well. Participants that we've had so far, we've had many who've had good responses. Um, and the pomalidomide trial that we're using for FDA registration, if it goes well, that one closed to accrual for right now. So unless they need to replace some participants, now sometimes happens. That one's closed. So for KS, we have that. And then while I'm just going to plug really quickly. We have some lymphoma stuff that's coming down the pipe soon. We have one that was open that has to reopen once an amendment comes through for plasmablastic lymphomas, both HIV and without HIV. Um, I'm going to try and get a CAR T trial open for relapse refractory um, lymphoma, again, once that gets amended. And then we have actually very relevant to the primary care setting. Miley is leading the charge for our trial looking at tobacco cessation and lung cancer
Mm.
screening, where if somebody is smoking, they can get their low dose CT and this app that helps with cessation and nicotine therapy that helps with cessation. All of that, we're trying to get persons onto that protocol and having trouble. We thought it would be easy to enroll. We're having trouble getting any enrollment. It probably is going to close later this year, so it'd be really nice if we could contribute to that and let our patients know that that's an option for them.
Very last one before we close from David. We often hear in the context of visual identification of lesions that we know it when we see it. What work
Mm.
is being done to improve this?
Yeah, another good question. So we biopsy for sure to confirm if we don't have a biopsy confirmation from before. I had this camera that did like sort of three dimensional imaging where it would take images at multiple planes of focus at once and merge them in. And we were looking at that. There was a publication a few years ago with our colleagues that used it. I want to say in Mozambique, um, with the KS clinic there, to look at sort of the utility of that. And I think that would be a nice objective way to sort of measure our responses on our therapies. Right now, I get out my little tape measure and I feel things if they're raised or flat and, measure things, but there's a little bit of variability from time to time and whatnot when we do that. So that would be really helpful, is more like camera techniques. And as the mobile phone cameras are getting better and better, that might become something that scales to a level that we can roll it out more broadly.
Cool. Well, thank you very much, Erin, for a wonderful talk. Oh, I see Paloma's asking for the smoking cessation study. How can we
Yeah.
refer? Do you know?
You can let Miley know, or
Okay,
Allison Walsh is our coordinator based at Hillcrest. And so I can, if you want to email me, I can get you in contact with the right people.
awesome. All
Yeah.
right. Well, thanks. It's time, so I'll let everyone go. But thanks again, Erin, for a wonderful talk. Please read all the wonderful comments from your colleagues, and thanks again. And I think just a reminder, I guess this tomorrow is Tijuana Pride, I believe. So if you're interested, go check it out. So,
Thank
all right.
you.
Thank you, everyone. All
Great
right.
to
Have a
see you
good
all.
day. Bye bye.